Concepts covered will entail acid-base balance, inflammation, and oxygenation. Central nervous system control is involved in the respiratory status management. The brain of younger children is immature and has a more difficult time in controlling respiratory status. Their airways are smaller, which makes it harder for them to get air in and out. The chest wall and the respiratory muscles are less developed. So again, that makes it more difficult for them to, their chest to expand and contract. And their lung tissue, they have fewer alveoli. So all of these things can put a younger child into respiratory distress much quicker than an adult or an older child. This is a review of pediatric respiratory anatomy, and you can see when you have 50% reduction in an infant, how small the airway becomes, as opposed to a 25% reduction in an adult. The shape of the larynx can also be problematic, so it makes it difficult with assessment when they go down to do like bronchoscopy. It's harder, it's more cone-shaped and harder to perform that procedure, which can result in complications. Children are also more likely to get that airway obstructed, from like small objects, choking, things like that, but also, mucus. Signs of upper airway obstruction include mouth breathing, loud snoring, apnea, in extreme cases, stridor, and drooling. So we want to make sure that we teach the parents preventive strategies for choking, review the foods that are most commonly choked on, like peanuts, popcorn, hot dogs, grapes, things like that, coins, small objects. And you see the alveoli, like we said, there's fewer alveoli, so less area for gas exchange to take place. Signs and symptoms, fever. Meningismus is stiff neck and headache, so signs of like meningitis. Anorexia, vomiting, diarrhea, abdominal pain, nasal congestion, nasal discharge, cough, respiratory sounds like grunting, sore throat, and retractions. Grunting is moaning or crying like sounds that are with forceful expiration against the vocal cords. Stridor is a high-pitched musical sound. Normal acid-base balance is essential to physiological functioning. It's maintained through the interaction of a complex system of buffers, respiratory compensation, and metabolic components of kidney function. Review the terms hypoxemia, which is low O2 in the blood, hypercapnia or hypercarbia, which is high CO2 in the blood, and hypoxia is low O2 in the tissues. Most of the time when blood gases are drawn on infants, they use venous blood samples, so the norms differ a little bit, as you can see here from what you're used to seeing with an arterial blood gas of an adult. The advantages of doing a venous blood gas on children is there's decreased pain, it's one puncture, it's decreased cost, and decreased complications like arterial laceration, hematoma, and thrombosis are avoided by doing a venous sample. So the main goal is to correct the primary cause of the respiratory issue. Nursing wants to monitor the respiratory status, maintain a clear airway, maintain normal body temperature, monitor level of consciousness, monitor the labs, monitor I&O, and involve other team members like respiratory therapy, physicians, advanced practice nurses. Respiratory failure, so respiratory insufficiency is an increased work of breathing with adequate gases, so they're able to maintain their gases, but it's harder for them to do. And then there's the inability to maintain normal blood gases. Respiratory failure is inability of respiratory apparatus to maintain adequate O2 with hypercapnia, and then you have apnea where the patient is not breathing. In some cases, we then have to resort to artificial airways, and mechanical ventilation may become necessary depending on the respiratory status of the child. Respiratory illnesses require immediate and aggressive intervention because of those things we talked about earlier, less alveoli, smaller airways. It becomes more of an emergent issue than with adults. You want to assess the patency of the airway, begin oxygen therapy, administer any medications needed, use airway clearance techniques such as suctioning. Sometimes we need artificial airways, mechanical ventilation, and sometimes they need tracheostomies. Oxygen is usually administered at lower levels to children. Too much for too long can result in fibrosis of lung tissue. So you want to use the least amount to maintain an oxygen saturation of 93% or greater. Here's some things that we use to try to maintain airways in children. Peak flow meters, which we'll talk about more of this in class. So peak flow meters, inhalers, we often use spacers because it helps to trap the medication so that the child is able to absorb it. The little penguin down there is a nebulizer. We use things like pinwheels, getting them to blow a pinwheel instead of using an ISB. It makes it more fun for them. And chest physiotherapy, which is chest PT that we do a lot on adults, somewhat different technique used on children, but is to try to mobilize the mucus. I'm sure as you are at pediatric specialty, you review trach care and suctioning. So the first condition we're going to talk about is inflammation and tonsillitis. So this occurs most commonly in school-age children. It's repeated infections that cause swelling. The causative organisms tend to be group A beta hemolytic strep, H influenza, H flu, and that's what the Hib vaccine is now for, pneumococcus, and that's what the Prevnar vaccine is now for, and then a variety of viral agents. It can be an acute problem or chronic problem. We measure the tonsils based on where they are in relation to the uvula. So you'll have a +1, 2, 3, or 4, and 4 is when they're kissing or touching each other. Some signs and symptoms are sore throat, difficulty swallowing, inflamed tonsils and surrounding tissue, exudate on tonsils, as you can see in that bottom left-hand picture, adenitis, so the adenoids can also become inflamed, the kissing tonsils, as you can see in the picture to the right middle, and then again at the bottom, they're pretty close to touching, they're on the uvula. That picture on the right is more chronic tonsil inflammation. You can see it doesn't look real red. There's no exudate there, so that's a chronic problem. Or the one there at the bottom that you see is more indicative of an acute problem with the extreme erythema and swelling. The picture to the bottom right, where you see the petechiae, that's usually a pretty good indication of strep when we see that. So the palatal petechiae, and then they can have foul breath from the infection. So to diagnose tonsillitis, we do a physical exam. We visually inspect the throat, use a tongue blade. A lot of times children have trouble keeping their tongue down. They don't like the tongue blades. You got to kind of be quick about getting a good look. If they're crying, sometimes they open their mouth. That can make it easier. And most of the time we do throat cultures to determine the causative organism if it is a strep infection. So normally they get put on antibiotics. They may need tonsillectomies and adenoidectomies. A lot of times the adenoids are also causative and can cause issues, so they'll just remove both of them. They want sore throats that are caused by group A beta hemolytic strep. Frequent infections, more than 5 in a year, or I've seen greater than 3 in 6 months. They want the child to be symptomatic in order to remove them. The tonsils do serve a purpose. They're part of our lymph system. They're kind of the garbage collection system for our body when we have infections. So we're not as quick to pull them out as we used to be. It is costly to parents to keep having a child with tonsillitis. There's missed work, missed school for the child, and the medical expense of it. Here are some antibiotics that can be used to treat group A beta hemolytic strep. You can see the penicillins are good choices along with your cephalosporins. That's your cephalexin and cefadroxil. Your clindamycin, azithromycin, and clarithromycin are all macrolides, so they fall in the erythromycin family. The nice thing about penicillin G, that benzathine, penicillin G, is that you can give it as an IM injection. It's a one-time dose. Sometimes kids come in and the tonsils are so swollen that it's difficult to get them to swallow pills or even liquids sometimes, so that is a nice option to have. Tonsillectomy is routinely done as an outpatient procedure. 2 to 3 weeks following an acute infection. They don't want them to have an active infection. Usually put them on antibiotics prophylactically to prevent that from happening so that they can remove the tonsils. Nursing care post-op is to observe for potential hemorrhage. They usually have an ice collar around their neck for comfort. Prone positioning, you want to observe for vomiting. Suctioning as necessary. Monitor vital signs. We're looking for bleeding and hemorrhage, so increased pulse, decreased blood pressure. Pain management for the child, they're usually put on like Q4-hour medication to help with pain, and can start on ice chips once they're able. So again, one of the biggest instructions for the nursing staff as well as the parent or caregiver is to observe for bleeding. Some signs of that can be frequent swallowing, coughing, or vomiting blood, and again, it's bright red blood. If we're seeing dark brown, that's older bleeding, which is possible following the surgery. They usually want them quiet activity for at least a week, back to school in 1 to 2 weeks, or after follow-up at about 8 days post-op. The scabs over the tonsils can come off, and that is another critical time that they could hemorrhage. So they usually try to withhold them from school during that period of time. Pain medication every 4 to 6 hours. Again, ice collar, halitosis against that bad breath smell, mouth care, encourage fluids. Their diet, they should be avoiding red, juices and things like that because of, if they're to vomit, you're not sure if it's blood or what they had. And monitor for fevers more than 101. We avoid sticking anything in their mouth like tongue blades, straws, anything that could possibly, cause trauma to the back of their throat and cause bleeding. Ear pain can be present throughout the recovery process. It's not really concerning. That's something that could be there. No lifting, bending, or straining for 2 weeks. Post-operative scabs, like I said, fall off about the end of the first week, and that increases risk of bleeding. This is just kind of a review of anatomy. There's an article for you guys to read that I have on D2L. It's about epiglottitis, but we're also going to talk about croup and bronchiolitis. RSV is a viral illness, respiratory syncytial virus. It's an adenovirus parainfluenza, causes great issues with the airways of children till they're about 18 months. They are at risk, and it greatly decreases gas exchange. A lot of kids can be hospitalized or in very acute condition because of this illness. Signs and symptoms are increased respiratory rate, intermittent fever, cough, wheezing, retractions, decreased O2 sats, apnea, hypercapnia, and decreased breath sounds. Serious complications include airway obstruction, impaired gas exchange. Full respiratory assessment is necessary. You can diagnose RSV from a nasal swab. Many times they'll undergo chest x-ray to rule out, like pneumonia, and CVC and BMP. High humidity oxygen, increased fluid intake, rest, bronchodilators, corticosteroids, diuretics. RSV actually invades the cells and then kind of explodes and causes a lot of fluid and mucus, and so they will use diuretics to try to clear some of that. You want to monitor O2 sats. Prophylactically, you can use something called Synagis. So infants that are at high risk, so born prematurely, have cystic fibrosis, other things, you can give Synagis prophylactically every month, especially during the winter. So it'll start late fall and into winter for 6 months. Ribavirin or Virazole can be used when they have an active infection. These children be put in contact isolation, good hand washing, continuous pulse ox. We want to stop PO feeds if the respiratory rate's above 60 in an infant. Continue with good respiratory assessment, positioning, teaching, parental support. It's very scary for parents. Again, it's usually a very young child. Most of the time I've seen it less than 6 months, but it can be up to 18 months, usually admitted to the hospital with close observation. If they're acutely sick. Now, routinely, if they feel the parents can handle this at home, they will send them home with nebulizer treatments. So it really depends on how quickly they catch the infection and how serious the infection is for the child, whether or not they'll hospitalize them. Signs of respiratory distress include grunting, retractions, pallor, and cyanosis. You want to teach the parents how to count the respiratory rate. You want to promote fluids and observe for dehydration. You want to suction the nose and mouth. Again, good hand washing and no smoking. A 5-month-old, actually, we're going to save the questions for class, so I'm going to skip by these quickly. We're going to cover cystic fibrosis, and this is a disorder of the exocrine glands, which are mucus-producing cells, and it affects the lungs, pancreas, and sweat glands of children with this disorder. It's the most serious lung problem of children in the United States. It's an inherited congenital disorder, so it's autosomal recessive, and it affects both sexes equally. Symptoms include obstruction of the bronchioles, which results in barrel-shaped chest and clubbed fingers. Remember, things like barrel-shaped chest and clubbed fingers are a result of oxygen deprivation for a longer period of time. This is not an acute thing. This is usually some time if the child's been robbed of oxygen before those things will happen. The right ventricle can enlarge. They can get frequent respiratory infections, which then causes further damage to the lungs. Chronic cough, dyspnea, wheezing, cyanosis, irritability, fatigue, and weakness are some other symptoms. The pancreas is secretion of digestive enzymes are blocked. Food's not able to be digested, especially fats and proteins. You can see the picture there of the child, the muscle wasting and stuff in the legs. Steatorrhea is a symptom where there's a lot of fat in the stool because the child's unable to metabolize that. Results in malnutrition, abdomen becomes distended, buttocks and thighs can atrophy. They can have failure to grow and sallow skin. Children in the state of Pennsylvania are screened for cystic fibrosis upon birth in that newborn screening. So the sweat glands are affected. Sweat, tears, and saliva are abnormally salty, and there's an increase in sodium chloride, and they will do a sweat test as a screening for these kids to determine if they do have cystic fibrosis, and then they can do some more specific genetic testing. Complications that are sometimes seen in children with cystic fibrosis include a rectal prolapse in infants. So that sometimes is the first symptom. They can have liver cirrhosis, osteoporosis, cor pulmonale, the meconium ileus, which we see in 7 to 10% of all newborns, and frequent pneumonia. The cor pulmonale is that hypertrophy of the right ventricle. Overall, we want to look at the physical exam, general condition, muscle mass, muscle tone, behavior, abdominal assessment, skin, rectum, diagnostic tests, again, our sweat test, chest x-ray, pulmonary function tests, and like I said, more specific genetic testing if diagnosed with a sweat test. So they need good respiratory care, oxygen, antibiotics, mucolytics, things like Mucinex or guaifenesin to help thin out the mucus, aerosolized bronchodilators. They do a lot of postural drainage. As you can see, the mom on the couch there with the child leaning over her helps to drain different lobes of the lung. Good chest percussion to try to loosen the secretions. They do a lot of breathing exercises. They use the vests that shake them to, again, try to shake the mucus and make it easier to expectorate. They also use flutter valves that the child blows into it, flutters back, vibrates back, and again helps to try to decrease the mucus. So we use a lot of respiratory medications, obviously, with these children, and they also need all their routine vaccinations. You want to make sure they're up to date on their Hib and their Prevnar. Again, trying to prevent all those other infections. So you can use things like bronchodilators, which include all your short-acting betas, which are your Alupent, Provenal, Brethine, Xopenex, your albuterol especially. Xopenex's claim to fame there is it does not increase heart rate. You know, that is a side effect of albuterol, increased heart rate, jitteriness. Xopenex does not do that, so that if you have a child with a heart issue, they can get that med approved, and then it doesn't cause the increase in heart rate. You can use cholinergic blockers like Atrovent, inhaled antibiotics like tobramycin, and mucolytic agents with the Dornase alpha, which is specific for your cystic fibrosis patients to try to decrease the mucus. Interdisciplinary interventions is they need good gastrointestinal care. They usually want them to eat 1.5 to 2 times normal caloric intake for their age to keep up with the growth and development. High carbohydrate, high protein, no restriction on fats. They get 3 meals a day plus 2 snacks. More salt, especially in the summer months because of them sweating out the excess amount of salt. You want to feed them in a calm and unhurried manner. Monitor weight and growth against our growth charts. They look at albumin, pre-albumin. Remember, those things show pre-albumin shows short-term malnutrition. Albumin shows long-term malnutrition. Glucose and electrolytes. CBC. These children are given oral pancreatic enzymes. So they're in capsules. They can either swallow them or sprinkle them on the food. And they monitor how well that's working or whether they need more based on their weight gain and what their stools look like. If they're still having a lot of steatorrhea, then they'll increase the amount of pancreatic enzyme. Some children also need nutritional supplements if their cases are more severe. So we use the oral pancreatic enzymes. Pancrease, Viocase are some of the names that you'll see, available in powder and capsules. It's again determined by the color and consistency of stools. We also need usually to supplement A, D, E, and K because of those being the fat-soluble vitamins. They will use medium-chain triglyceride oil to try to increase their fat intake. Sometimes they need H2 blockers to help with stomach issues like famotidine, cimetidine, or ranitidine. And then your prokinetic agents like Reglan, which helps increase how quickly things move through the digestive tract. Respiratory therapy obviously is heavily involved with these patients. We get a link to social services. There's a lot of state and federal programs to help these families out. This is very costly and time-intensive care for a lot of these children. We hook them up with appropriate referrals, physical therapy, to try to get the most out of their breathing, their muscles. You want to evaluate the ability to complete their ADLs, monitor their endurance, make sure they're getting adequate exercise. Child life services is kind of like the tutor. A lot of times that's on the floor. It assists with coping to hospitalization and assists with education. So we want to coordinate care, monitor overall response to therapies, initiate and maintain IV lines, measure height and weight. Again, provide emotional support for the parent, child, and school readiness. Transplant is sometimes an option for these children. We'll talk next week about the case of the young girl who was on the child list for a transplant, lung transplant, and they got her bumped up to the adult list because very few children organs become available. And she was going to die without a transplant, but we'll talk about the issues that also come along with transplant of these organs. There's many obstacles, constant treatments, restrictions. It's a lot of stress and burden on the family. Cold season, hand washing, flu season, they need to be very carefully kept away from crowds and things during those times. They get their vaccines. You want a good educational plan. There's career and vocational choices. What would be an appropriate thing for them as far as furthering a career. A lot of them are used to being in a pediatric setting, and then when they become 21, you have to transition them to adult care. Some need to make end-of-life care decisions depending on the child. We're also going to talk about something called B. cepacia, which is an infection that's pretty prevalent in cystic fibrosis patients, but if they get it, it's very concerning. There's a lot of restrictions on cystic fibrosis patients being with each other. They no longer can do that. If there's an in-house environment, so not outside, but an inside event, only one child with cystic fibrosis or one person with cystic fibrosis can attend that event because they do not want them sharing their bacterias. Same thing if it's an outdoor event, they need to be kept 6 feet away from each other. They wear pins so that they're recognized as being another cystic fibrosis patient. So it's kind of hard for these kids. They don't have the camaraderie of being around other patients or other children with their disease because they need to keep them separated because of these infections. So that's another whole layer of burden on the families and on the children. We're also going to talk about ear infections, otitis media. It's an inflammation of the middle ear. It can be classified as acute, chronic, recurrent, or an effusion. You can see the picture to the right is an effusion. You can see the fluid that's behind the eardrum. The one on the left there is a normal eardrum, and then the one in the middle is an acute infection. Things that contribute to acute otitis media are the young age of the child. If they have any allergies, like seasonal allergies, there's a genetic predisposition. Any craniofacial abnormalities, like kids with Down syndrome, because of the lower set ears, increased risk. Presence of other siblings can also be an issue. Infants that are bottle fed are more likely to get the infection because they feel like they have to suck harder. Excessive pacifier use because it causes equilibrium issues with the eustachian tube. Exposure to passive smoke. Being in daycare, and their eustachian tube is shorter and wider and allows easier for infection. Many of the times the causative organisms are pneumococci, H. flu, or MCAT, which is Moraxella catarrhalis. Otitis media usually appears a few days after the start of a respiratory infection, and you have to be careful because if they're crying, the eardrum can actually appear redder than it would be if they weren't crying. Assessment-wise, they'll complain of ear pain, being irritable, they can tug on their ears, changes in sleeping pattern, may have fever present, may have signs of an upper respiratory infection, ear drainage, and hearing loss. Every time a child has an ear infection, they feel that the hearing, if they're placed on an antibiotic, the hearing's affected for at least a month. So this is very important with speech development. It can affect speech development if they're having chronic ear infections. We diagnose this by doing assessment of the tympanic membrane with direct visualization using an otoscope. Remember, when you're putting drops in or assessing a child's eardrum, for a child you want to pull the earlobe down and back, and for adult it's up. Possible nursing diagnosis are impaired comfort, risk for injury, risk for impaired verbal communication, and ineffective coping. All three of these must be met to diagnose with otitis media. It's history of acute onset of signs and symptoms, presence of a middle ear infusion, and signs and symptoms of middle ear inflammation. Medications you can use pain management like ibuprofen, acetaminophen, antibiotics. Amoxicillin is usually the drug of choice, but you can also use sulfa medications, cephalosporins, or macrolides. We encourage that young children are rechecked within 2 weeks after the antibiotic to assure resolution of the infection because of possible effects on hearing and speech development. Surgery is also an option where they can put in PE tubes and their pressure equalizer tubes to try to drain the fluid is usually the cause, the buildup of fluid. So if we can keep the fluid drained out of the middle ear, most of the time that can help prevent infection. We want to make sure we encourage vaccinations because, again, we talked about H. flu being one of the causes of otitis media and pneumococcal as well. So the Prevnar and the Hib vaccines are important, along with annual flu vaccines. Conjunctivitis is inflammation in and around the eye. Causes can be bacterial, viral, allergic, or irritative. You will see erythematous, conjunctiva, and sclera, sometimes purulent exudate. They can complain of light sensitivity and have pruritus, which is itching. Infants, we get a little bit more concerned with conjunctivitis because sometimes it's due to STDs that are obtained during delivery. So chlamydia, gonorrhea, herpes, and cytomegalovirus. That's why they use silver nitrate, erythromycin, or tetracycline at birth prevention of these infections because they can cause blindness if not treated early. You want to encourage good hand washing. Encourage correct administration of drops. Remember, you put it in the inner part of the lower canthus, inner canthus of the lower lid. Want to make sure that the dropper does not touch the eye. Want to assess visual acuity. If the person wears contact lenses, that puts an extra layer of concern. We tell them not to wear their contacts, throw them out if they're disposable, throw out the case, any kind of eye makeup because you can, have contaminated those things. You also need to assess for injury or a foreign body that might be causing those symptoms. If it's bacterial conjunctivitis, we use antibiotic drops. You can use sulfas like Blef10, erythromycin, tobramycin, ofloxacin, which is like a Cipro type drop. If it's allergic conjunctivitis, you can use things like Optivar, Zaditer, or Patanol, and then NSAIDs like Ketorolac, which is Toradol, if it's just more of an inflammation. Okay, that's going to conclude this podcast on respiratory and sensory disorders.